Rajesh A, Professor and Head of Department of Psychiatry at Surbi Institute of Medical Science, Siddipet, Telangana. He's the ex-president of Hyderabad Psychiatric Society and Director Retreat Hospital, Malakpet, Hyderabad. I welcome you both. Without further ado, I call our first presenter, Dr. Dakshina Patel. Please remember, you will have 6 minutes for the presentation and 2 minutes for the question and discussion. Yes, sir.
I'll start. Good morning to the judges and one and all present here. My topic for today is aggression and impulsivity in suicide attempters, a case control study in a tertiary care center in Bangalore. The introduction. Suicide attempt is defined as a non-fatal, self-directed, potentially injurious behavior with an intent to die as a result of this behavior, but it may or may not result in injury. So across the world, estimated number of suicide attempts are 9 to 36 million, where one attempt occurs every 3 seconds. Of all those who participate in this, 1/3 repeat this activity within a year and 10% finally complete the act. There are around 7 to 10 suicide attempts for every one completed suicide. So a suicide attempt can be predictive for further attempts, which may have an approximate lifetime prevalence in India of 1.9%, which shows that at least 1 of 50 people have had a suicide attempt at least once in their lifetime. Aggressive traits are an individual's propensity to behave in a violent manner, which is a collection of emotional and behavioral characteristics like hostility, rage, and a lack of empathy for others and impulsive decision making. Impulsive traits, they incorporate a wide range of behaviors that show poor planning, hasty decision making without thinking through the repercussions, sensation seeking, risk taking, and an inability to control reactions and taking decisions which seem right in the moment without thinking about the future. Need for the study. It's a major public health issue in India, with rates significantly higher than the global average. Understanding these traits in suicide attempters is critical for prevention. And limited data exists on these traits in Indian populations compared to how many studies are done in the Western countries. And it addresses the need for culturally specific research on these traits in suicide attempters. Current assessments focus on diagnosis but often overlook personality traits. So identifying this can enhance early detection and intervention strategies. In India, the interplay of cultural, social, and familial factors play a significant role, like traditional gender roles, societal expectations, familial pressures often exacerbate the mental health challenges, contributing to the reluctance to seek help. Moreover, the stigma associated with with mental illnesses can lead to underreporting of attempts and other underlying psychological issues. Objectives is to assess aggressive and impulsive traits in suicide attempters and establish an association between them. And as I said previously, investigate the prevalence and impact of these among individuals who have attempted suicide in India. Methodology. The study design is a case control study conducted in Rajarajeshwari Medical Hospital, Bangalore. Duration was 4 months with a sample size of 120 participants, which is 60 cases and 60 controls. Data on demographic details and the details of the suicide attempt were collected, and the sampling technique used was purposive sampling, and ethical committee approval was taken. The study tools. Participants completed 2 assessments. First was the Best-Perry Aggression Questionnaire, which is used to measure different types of aggression, consisting of 29 questions with 4 domains, which is physical aggression, verbal aggression, anger, and hostility. Barrett's Impulsiveness Scale. This is a scale of 30 questions used to assess different aspects like motor, attention, non-planning, and impulsiveness, and it's assessed on a 4-point Likert scale. So these are the 2 questionnaires. The inclusion criteria were 18 to 65 years of both genders and who have attempted suicide within last 1 week and who have history of any other psychiatric condition and suicide attempts. Exclusions criteria were individuals in delirium and who were unable to complete the study due to any physical or psychological condition. These were the results where it was seen that the mean aggressive trait score in patients was quite significantly higher than the control group. This was the graph for the impulsive trait, where again it shows that patients had a little significantly higher score than controls. This was the density of scores, which shows that there's an overlap between the impulsive trait in the control group and the case group, and a significant difference in the aggressive traits in the control and patient group. I'll go to the next slide, which explains this. So patients consistently exhibit higher mean scores for both aggressive and impulsive traits compared to the control group. So it suggests that individuals in patient group are more prone to reactivity, aggression, or impulsivity. So the density plot, which I showed previously, had overlapping distributions, shows that some individuals, even in the control group, may have high impulsive scores, signaling at-risk behavior. So not all patients had high impulsivity. So it shows that it cannot be a single factor which can make the patient prone to a suicide attempt, and it's influenced by many other factors. Aggression as impulsivity as a risk factor, it shows the importance of screening for impulsive behavior as a part of suicide prevention strategies, and interventions like DBT could reduce further suicide risk. Aggression, although not statistically significant, it may still exacerbate the risk combined with impulsivity. Anger management programs may offer additional value for individuals with elevated aggression. So overlap between these groups, presence of moderate impulsivity and aggression suggests that screening in non-clinical population could identify at-risk individuals before they reach a crisis. This I have previously explained. This is just the p-values, 0.005 and in impulsivity and 0.07 in aggression.
Your time is up.
A study previously shows that these two support my study, where 215 suicide attempts were analyzed and 148 healthy controls were analyzed, and it showed positive relation between aggression and impulsive scores with suicide attempters. In conclusion, I would like to say the study indicates that individuals who attempt suicide exhibit higher levels of impulsivity and aggression compared to those who do not, and a lot of other factors are always present coexisting with these traits, and they may contribute to a greater risk of suicidal behavior by reducing threshold if at all any suicidal ideation is present secondary to any psychiatric condition. And targeted interventions aimed at managing impulsivity and aggression could therefore play a crucial role in suicide prevention. These are my references. Thank you so much.
You said that you collected the history from the suicide attempters within 1 week of attempt, isn't it?
Yes.
Yeah. That was collected from the patient or from the attenders actually?
Ma'am, actually patient first, ma'am, and then it was corroborated with the attenders. So it was well corroborated between both of them.
Any history of deliberate self-harm in the past in the patients that you studied actually? 60 patients and 60 controls you studied?
Ma'am, actually I did not mention it here, but a few of them did have a lot of repeated attempts, which especially they had a lot of emotionally unstable traits where they repeatedly keep having deliberate self-harm. So most of them did have a previous history, ma'am.
In what way your study is different from directly saying that emotionally unstable and impulsive individuals are likely at risk of suicide? In what way your study is different from that?
Ma'am, that they are not the only factors. There are many other factors which contribute.
So you mean to say it is always better to screen a person whoever has attempted suicide for these traits?
Yes.
What do you mean by purposive sampling?
So where we collect only data from a specific, like we have this characteristic which we look for in the population and take only them for our studies.
What do you mean by NSSI? non-suicidal, self-injury.
Self-injury, okay, yes.
So, you have chosen 2 scales, correct? Are there any other scales which measure this impulsive interpretation?
So there's something from Dunk. I had mentioned it, one of the studies they'd used. Yes, a bus Durkee hostility.
Usually for free papers, what you have to do is you have to reduce the number of slides. Okay?
Yes.
At least reduce. You could have avoided the 2 or 3 slides.
Yes.
Where you have given some information, correct? So you should stick to only the study which you have done, and try to avoid 1 or 2 slides so that it basically saves time.
Yes, sir. Thank you so much.
Thank you, Dr. Lakshana. Our next presenter is Dr. Madhavi Puri.
Good morning. I'm Dr. Madhavi Puri. Today I'll be presenting on patient waiting time in psychiatric outpatient department, which was part of a clinical audit. So when we thought about doing a clinical audit, the first question was, what do we study? So we decided to study the patient waiting time because it is a key performance indicator as per NABH. It is a tangible and measurable measure, and also that it causes distress not only in patients but also in doctors, and it is a objective measure of patient satisfaction, and we wanted to see what happens in a tertiary care teaching hospital. So coming to what is an acceptable time, it was very difficult even through literature review to find out, especially for psychiatry, that if there are any guidelines or recommendations. So we found no guidelines or recommendations in India. However, on an average, in developing countries, the time of 2 hours was noted. So our objectives were to determine the average waiting time of patients in the first contact OPD and to recommend appropriate interventions to optimize or minimize the waiting period in the OPD. So we looked at the first contact OPD of a tertiary teaching hospital in Bengaluru, and we included all patients who attended the OPD under the unit for 4 weeks in December of 2023. The details of the patient, time of entry, exit, the time taken to move through various stages of consultation was recorded using a proforma. So when the patient comes, initially they come to the common registration area where a slot is provided, and from there they are either referred to the GDMO or the psychiatry OPD. We also receive referrals from other departments. From here, the SR on duty allots the patient either to JRs or SRs, or they refer the patients to emergency. So this was a proforma we used with the events and the timestamp, and this is a photograph of a screening slip, which also above the barcode is a reporting time, which over here states 11:30, and that is the time which is allotted to the patient to come to the OPD. So what we found when we looked at the distribution of patients as per allotted time, that is the time on the screening slip when they're supposed to come to the OPD, and the reporting time, that's when they're actually coming to the OPD. So we found a uniform distribution of time slot of registration, which was automated, so we saw uniformity. However, maximum patients were just taking the registration form and coming to the OPD between 9 and 10 a.m. So the time to seeing a doctor first, that was median of 46 minutes with a range from 6 minutes to 4 hours and 2 minutes, and with an average of 63 minutes. 86% of the patients were seen within 2 hours of their arrival to the OPD. Now, coming to time to be seen by a consultant or SR, which could be directly or as a discussion for a JR, median time was 77 minutes and 75% of the patients were seen within 2 hours. So majority of the patients were coming directly after registration, maximum were reporting between 9 and 10 a.m. and median time taken was around 46 minutes. So we conducted the same audit in the same unit in December of 2021. Interestingly, we found that the average time seemed to have increased from 50 minutes to 63 minutes. However, the average time to be seen by a consultant, SR, and the percentage of patients leaving in the first 2 hours remained nearly same. So we thought about what's happening and why are we getting this finding, and we looked at the reporting times of the patients between 2021 and 2023. So in 2021, which is in orange, the cases were reporting very uniformly to the OPD in a scattered manner, which we assumed, and when we went back and looked into it, appeared to be due to COVID-related social distancing. During the current audit, we found that most of the patients are reporting between 9 and 10 a.m., leading to clustering and increased waiting time, leading to distress again in both patients and the doctors. So we had made certain recommendations previously, which included a token system, display system, and additional human resources. Some additional staff was appointed to the OPD to address patient inquiries. So we discussed it with the OPD staff, we discussed it with the doctors, and we discussed it with some patients to see exactly what's happening and did a fishbone analysis. So the doctor-related factors seem to be language barrier, complex cases requiring discussion with the senior doctor, cases requiring psychosocial interventions needing liaison. There were some process-related issues, which included a no-token system. There was no display, there was non-availability of translators, and there's old follow-up patients referred by mistake to the new patients, which increased the time spent with them and increased the waiting time for other patients. There were some patient-related factors, which were sometimes they were absent on call for multiple reasons. It could be because they have not arrived. It could be because they've gone for meals. Sometimes a relative has taken the paper and they're waiting for the patient to come. Sometimes a relative is having a consultation in a different department. And sometimes they want to see a specific doctor, so it takes time. So what we learned from our from this study is that existing OPD waiting time for first contact patients is reasonable as per the patient load and profile in a tertiary care institute. However, this study did help us identify certain areas that can be worked upon to improve patient satisfaction, which is our primary concern, and possibly reduce patient waiting time further. Regular monitoring of this indicator will ensure sustained quality of care. Yeah, thank you. That's my presentation.
I think this is something different study from the run-of-the-mill studies. So I found it to be interesting. I should appreciate you for using such often neglected issue. But one thing I just wanted to ask you. Did you find any similar study done by anyone?
Sir, there were some studies. One was from Yennapoya in 2018. The other was from Sayana Hospital in, I'm not sure, Mumbai. I'm not sure about the year. So in that, they found an average waiting time of 40 to 44 minutes. However, they were done in a setup which is a general hospital setup, and they have a psychiatry department. Whereas in our setup, it's a big psychiatry department which has a load of patients who are coming for second, third opinions, and it takes time. And a variety of patients from different parts of the country. So we felt that for our study, we did not get a good comparison from previous studies. So it felt that we are adding something more to the literature.
So do you want to send these recommendations to the institute?
So not yet. We want to conduct it further because we did find some disparity in the first and second studies. So we are going to repeat it, and then we are going to give, we would like to discuss it, because there is actually, if someone says ask, there is no way to tell what is an average waiting time.
So who were the participants, who did the study actually? Yourself and
I did.
Only yourself?
Only I did, sir. I mean, the consultants were also involved. I mean, I collected the data. Sorry.
How many patients in general did you actually take up for the study?
There were 258 patients.
258.
Some patients, I mean, we attached the form to the screening slip.
How many were, repeatedly, follow-up patients? How many were referrals and how many were new cases?
Ma'am, they were all new cases.
All new
We wanted to see only the first
so
contact.
No referrals?
Referrals were there from child psychiatry, neurology, and neurosurgery. There were 20% were referrals.
20%?
Yes.
Referrals. They were all from within the institute or from outside?
Ma'am, within the institute. So what we found was that some, as I mentioned initially, some patients go to GDMO and some patients directly, they come with a referral. So those were around 40% of patients.
Okay.
So we are assuming they came with a referral.
Ideally, it is said that the first point of contact when the patient arrives to the OPD, within 20 minutes at least, the junior most doctor should see the patient and
Yes,
all
ma'am.
the vitals and everything should be examined. So 2 hours may be a time for detailed assessment of the patient.
Yes.
But otherwise, the first point of contact should happen between 15 to 20 minutes.
Yes, sir. Thank you so much.
Thank you, Dr. Madhavi Puri. Our next presenter is Dr. Dhruv Mathur.
Good morning. I will be presenting my paper presentation titled Thank You Dear Tobacco, an analysis of motivations and experiences of tobacco use with patients of schizophrenia. This is a qualitative study. In comparison to the general population, we find that patients with schizophrenia who use tobacco do so with greater incidence and prevalence, and there is reduced rates of abstinence as well, which leads to a shortened lifespan by about 20%, which can be attributed to their tobacco use. The interactions of nicotine with neurobiological, psychological, and behavioral aspects are interwoven with components like the impact that dopamine has when it gets released in the brain, secondary to the nicotine use. Also with the strategies to cope and handle with stressful circumstances. So people with schizophrenia, they often say that they use excessively to manage the cognitive deficiencies, lessen the side effects of the neuroleptic treatments, and to reduce the symptoms. They also report of isolation and lack of stimulation, loss of social and occupational functioning in addition to this. And even when residing in mental health care facilities, the urge to smoke persists, and additional interventions are needed to mitigate the same, which was found in a study in 2020. I found that research on tobacco use and cessation from the viewpoint of individuals associated with mental health is scarce. Additionally, amongst them, the research to examine factors that may affect the mindsets and opinions about smoking behaviors among individuals with schizophrenia are extremely scarce, especially in the Indian population. I conducted a qualitative study for which I developed an interview guide, which was a semi-structured interview, as well as a socio-demographic performer. The study was conducted at the Hombalaku Rehabilitation Center and the associated assertive community treatment program that's run by Manipal. The patients that were taken up for this were those diagnosed by consultants using the ICD-10 DCR criteria and had schizophrenia for the last 2 years, as well as comorbid and continuing tobacco use, and a written consent was taken. Those who were refusing consent and currently abstinent were excluded from the data, and I collected the data till saturation of the sample. I applied for the IEC approval and was able to attain it, approached the eligible candidates, and then took the written informed consent. Obtained the audio recorded interview, transcribed it, and then conducted a thematic analysis, which was using the Braun and Clark's method, and then generated the themes and sub-themes. We'll discuss the results in the discussion together. The results table shows that all of the patients were male and unmarried. Half of them were unemployed, and all of them had had a previous cessation attempt. Coping with symptoms emerged as a major theme during the interviews, and 2 sub-themes were identified as managing anxiety and negative thoughts, as well as hallucinations and emotional relief. Patient number 5 said that taking tobacco gives me a little bit of satisfaction, kind of relaxation. It gives rest for the mind a little bit. And for the sub-theme of hallucinations and emotional relief, patient 3 said, even if I smoke, I used to hear the voice. Still, I smoke to feel calm. We found that patients perceive a reduction in anxiety levels, which leads to a continued tobacco use. A qualitative study previously in 2005 supported this view and found that respondents attribute the effects of tobacco to be anxiolytic. Within this theme, our findings indicate that patients use tobacco to cope with symptoms rather than alter them. The interpretation was also noted in another qualitative study conducted in 2014, where patients identified tobacco use as a support to manage living with psychotic symptoms rather than modulating the intensity of the positive psychotic symptoms. Such effects are also supported by neurobiological findings, where nicotine contributes to anxiolysis in lower doses by inhibiting the beta-2 subunit of the nicotinic acetylcholine receptors. The second theme that came up in our research was to do with the patient's experiences of addiction and craving themselves. Within these two sub-themes were identified were a struggle to quit tobacco due to craving, as well as attempts made by the patients, but not being able to do so. Within the first sub-theme, the patient 1 mentioned the body is addicted. If you don't take it, you don't feel sleepy at night, you can't pay attention to your work. And within sub-theme 2, patient 6 echoed this, expressing frustration, saying, I've told them 100 times I cannot stop. I like to smoke. Our study is also consistent with other studies in finding that these patients with schizophrenia attribute craving and perceived benefits of tobacco as barriers to quitting. Studies show that patients with comorbid tobacco use and schizophrenia are less likely to want to stop. Craving appears in literature to be higher in tobacco users with schizophrenia when compared to tobacco use without schizophrenia. Craving for the substance as well as experience of coping has perhaps kept the patients engaged in tobacco use. The third theme dealt with the perceived benefit of provided by tobacco on cognitive function and activity levels. Within sub-theme 1, one of the patients noted it helps in studying and I don't feel sleepy. Another patient mentioned if I smoke 1 or 2 after 2 hours, it still keeps me fresh. The second sub-theme within this, one of the patients, patient 1, mentioned tobacco gives that effect. It makes me feel like working. Another patient mentioned I feel stiff in my body. When I take tobacco, I can work for a bit. The same qualitative study I had mentioned earlier by Esterberg and Compton in 2005 also highlighted reduction in negative symptoms experienced by the patients. Patients mostly started using tobacco after the onset of the illness to counteract medication side effects. Neurobiological studies by Kumari et al. In 2003 used fMRI studies to illustrate activation of cognitive circuitry after the nicotine administration. Previous studies have also shown improvement in attention after nicotine patch administration. The patients in our study reported being able to keep alert and an ability to stay attentive. The nicotinergic stimulation of dopamine in cortical neurons can lead to attenuation of the negative symptoms. The fourth and final theme that I identified, one of the patients, patient 1, said, I started when I was 16, my friends asked me to do it. And so this theme deals with the social aspects. With the second sub-theme within this, patient 1 also mentioned, when we smoke together, I feel more comfortable. It feels good to be with them. The interviews brought to light the patient's social experiences with tobacco, recounting how the use started and elaborating on the positive reinforcement brought about by the tobacco use with peers. In previous studies, patients with higher symptom severity reported poorer social adjustment. Tobacco users have also reported lower loneliness scores. And animal models also show that nicotine improves sociability in rats and treated with PCP to mimic schizophrenic effect on the brain. So in conclusion, I'd like to state that tobacco use provided temporary relief from anxiety, negative thoughts, and emotional distress caused by the hallucinations. Craving made quitting difficult, and most respondents feel trapped in a cycle of dependence. Respondents used tobacco to improve concentration and maintain energy. Most respondents started using tobacco socially, but gradually shifted to solitary use due to mental health related isolation, but found solace and social cohesion with other tobacco users. The take-home message is that there are perceived benefits of tobacco for these individuals. Understanding the individual motivation for the use may help plan better interventions, and staggered approach with more adaptive coping with illness and its effects may help achieve the requisite compliance from the patients. Thank you, and I apologize for going over time. These are my references.
A good presentation, but just a suggestion. Whatever patient said, whatever you have quoted, I think in that presentation, like sir already mentioned, for free paper, you should not quote all those things. Okay, because it will take away your time. What is necessary to be emphasized, you will not be able to do. Okay, that is a tip for every one of you. Okay. Secondly, you said regarding tobacco, were there any other comorbid substance use also
No.
with the patient?
Yeah, should have mentioned, but those were excluded. No other comorbid.
Excluded. This tobacco, whatever they were taking, was it before the onset of illness or after the onset of illness?
Mostly we found that tobacco use started after the onset of illness.
After the onset of illness. Okay. Which type of paranoid schizophrenia were they more the number of patients that you observed? Whom it was more positive symptoms predominantly, negative symptoms, or cluster of both?
So this was part of a larger study that I did. This was a qualitative aspect of it. What I haven't mentioned here is that most of them were part of a chronic sort of rehabilitation setting. So they had all had symptoms for a long, long time. When they were speaking about the positive symptoms, they were sort of recalling what was there previously. Whereas now mostly it's negative symptoms.
And one more last question. What was the intake of tobacco per day on on an average, like how much of small cigarettes or babies there?
Because the patient population is mostly in a rehabilitation setting, it was subdued as to what it would be if they were outside. They really wouldn't disclose that information because that would lead to other.
Because that you will be able to actually correlate, no, the intake of the substance and the symptomatology that they are manifesting with.
Yeah.
Very good presentation. One thing I liked about it is there are two sub-themes. The sub-theme part was quite good. But one thing is, did you try to think about doing fMRI in these type of patients?
As part of my study, sir, I did not. But it would be quite interesting to have a look at that aspect. Within each of the discussions, I tried to see other studies, qualitative studies, other quantitative studies, and then the neurobiological aspect. It does interest me to look at the neurobiological aspect, but I think that that's something I can do in the future.
And one more thing, you did mention the duration of the illness and the age of the patients. How many patients you are taking this?
6.
Only 6.
Yes, sir. We did it till saturation. Most of the answers kept repeating. And because most of the patients had negative symptoms, the way in which they were expressing themselves was also a little not so elaborate.
Only 6 patients.
Yes.
And what is the age distribution of these 6 patients?
Around middle age, sir. Around from 30s to mid 40s. I think the highest was
Duration of schizophrenia?
since adolescence. In all of them.
Mostly 15 to 20 years.
Yes.
The initiation of the substance would have been as a teenager itself. This could just be an exacerbation with the onset of symptoms, I would say. It cannot be something that he would have started soon after the onset of the illness per se. This would have been a habit even earlier.
Yes.
And
So one of them did say that I started using tobacco with friends and that made me more social. But from a file review and sort of asking them, it did seem that most of them started after they started taking medication.
No, that seems to be a little surprising because usually we expect nicotine, usage, then schizophrenia sets in, and schizophrenia exacerbates. That is usually what we see in our regular practice.
So as part of the literature review, there was conflicting evidence between the two also. That some studies found earlier use of tobacco and then that progressing into schizophrenia. Other studies have found the entire opposite, which I also found that there is onset of illness and then subsequently use of tobacco.
I think you can conduct it on a larger scale of
Yes.
and that will be more beneficial actually rather than just concluding with just 6
Yes.
The larger sample, sub-team part is quite interesting. You can just work on that.
Will do. Thank you so much.
Thank you, Dr. Dhruv. Our next presenter is Dr. Swati.
Another session is going to start very soon, so I request the rest of the participants to speed up. Maybe you can just ignore some slides.
Yeah, I'll try to finish it in time.
Just stick to the main slides.
Okay, sure. Thank you. Good morning, everyone. So, my title of my study is a study of psychological well-being and the prevalence of anxiety and depression. I'm a woman diagnosed with polycystic ovarian syndrome in a tertiary healthcare center. So, my study was done at my hospital in Bengaluru. Polycystic ovarian syndrome is a prevalent endocrine and metabolic disorder affecting women of reproductive age, as we all know. And according to the Indian Fertility Society prevalence ranges from 3.7 to 22.5%. And the classical features include menstrual irregularities, biochemical or clinical hyperandrogenism, and ultrasound appearance of polycystic ovaries. The most widely recognized hypothesis regarding the etiopathogenesis is that the development of polycystic ovarian syndrome is due to insulin resistance and hyperinsulinemia, which subsequently lead to hyperandrogenism. Endocrine and psychiatric disorders, especially mood disorders, seem to be interconnected and affecting each other. When I've reviewed the literature regarding the etiopathogenesis between PCOS and mood disorders, there's also very numerous literature showing that insulin resistance is something which is also seen in patients with mood disorders apparently. So the neuroendocrine systems are crucial not only in reproductive function but also in mood regulation. The higher prevalence of psychiatric disorders in patients with polycystic ovarian syndrome, especially depression and anxiety, may be both due to hyperandrogenism and the resulting somatic symptoms. So symptoms which include obesity, prevalent in 50% of cases, hysterism and acne, which result from increased androgen sensitivity. These symptoms can be stigmatizing and lower the quality of life and lead to depression and anxiety in these women. So the frequency of depression in female patients is variable in different studies, and so is anxiety. So the Indian literature on these aspects is inconclusive and inconsistent, and given the high prevalence of polycystic ovarian syndrome and the physical and psychological burden the disease appears to place on women, so the international evidence-based guidelines also suggest for the assessment and management of this condition and recommend that mental health problems in these women should be assessed and managed by respective healthcare professionals. So the aim of the study is to study the psychological well-being and prevalence of anxiety and depressive disorders among these women. And the objectives also were the same. Coming to methodology, the study setting, it is conducted in Department of Psychiatry at Ashram College, Andhra Pradesh, Eluru. The study period is from May to September 2024, and the study design is an analytical hospital-based cross-sectional study. These are the study tools I have used. So the inclusion criteria: patients diagnosed with PCOS as per Rotterdam's criteria in the gynecology OPD, and patients in the age group 18 to 45 years are taken, and patients who are willing to give the informed consent. Exclusion criteria: patients who are already diagnosed as having a prior mental illness, either by self-report on their history or as per past medical records, were excluded, and patients having any other concurrent significant medical illnesses were also excluded. So sample size was calculated by using the prevalence data in the previous Indian studies, and the average was taken, and it was rounded off to 40 patients in the age group of 18 to 45 years. These patients were diagnosed in the gynecology outpatient department, and those who fulfill the inclusion and exclusion criteria are then interviewed at the psychiatry OPD further. Coming to statistical analysis, the results. So these are the socio-demographic data. So majority of them were in the age group 18 to 25. Majority of them finished their college, and most of them were married. So when I've done the grading of anxiety and depression in these women, the prevalence of anxiety and depression was found. Prevalence of anxiety was found to be 45%, and depression was found to be 27.5%. Most of them, both anxiety and depression, have had mild scores on their gradings, and severe were very few. Among the most common symptoms, menstrual irregularities was highly reported, followed by weight gain and acne. So I also did a relation to test the association between the symptoms of PCOS and their association with anxiety or depression. So there is a significant association between symptoms of acne, menstrual irregularities, and infertility with anxiety. Similarly, there is a significant association between infertility and depression among women with PCOS. So I've already discussed most of it. The general health questionnaire, which I didn't include because of the lack of time limit and all, it consists of a 4-point Likert scale with low scores reflecting good psychological well-being and high scores reflecting distress. So high scores were reported by 14 females on factors corresponding to depression, and 20 reported high scores on factors corresponding to anxiety. 10 females reported higher scores on factors corresponding to coping difficulties, whereas high scores on factors corresponding to feelings of incompetence were found in 18 females. The similar findings were also observed in a study done in Mumbai and Telangana, where the prevalence of anxiety and depression were more in women with PCOS, and another study in Pakistan, where the prevalence of depression was much higher than the prevalence of anxiety. So in conclusion, the research highlights the level of psychological distress found in women with PCOS and an increased prevalence of depression and anxiety, hence the need for comprehensive assessment of all women for psychiatric comorbidities, particularly anxiety and depression. And given that lifestyle modifications are first-line treatment for polycystic ovarian syndrome, early screening and treatment of depression and anxiety are also essential for the overall comprehensive management and improved quality of life in this population. These are my references. Thank you.
Onset of PCOS and the manifestations of anxiety and depression, was it seen?
The duration was not seen. Usually these patients are actually referred from gyneco-PD because most of them were inconsistent either with the PCOS treatment or follow-up. So they, on further probing, when the gynec department found them to be somewhat symptoms of anxiety or depression, they would refer to us. So that is when we thought of doing this study and went. So we didn't.
Already?
Some of them were, ma'am. They were on medications.
Okay. Your study findings, does it bring any difference between married and unmarried? Do you want to comment on that?
Yeah, ma'am. Because infertility was seen in married population, there is a significant association in depressive symptoms. The anxiety part of it did not show much difference between married or non-married population, but the depression was significantly associated with infertility. So that would be a finding.
See, once the person is diagnosed with an illness, denial becomes the first thing. Acceptance is never there. So that induces anxiety in a big set of patients. But over a period of time, even with the failing treatments and infertility adding to it, with the cultural and the psychosocial factors, that amounts to depression. So both the things are entirely different because it is a heterogeneous group. You could have separately studied married population versus unmarried. Then it would have been more relevant that you can extend your study in that way.
Nothing to add. I don't agree with Madam. Segregating into married and unmarried, you highlight the aspect of infertility, which actually gives us to more psychology.
Thank you, Dr. Swati. Our next presenter is Dr. Shruti Sharma.
Good morning. My topic is frequency of restraint and factors associated with restraint in patients admitted in General Hospital Psychiatry Unit, a cross-sectional observational study. Coercive measures like mechanical restraint, seclusion, and compulsory medication are commonly used in psychiatric institutions to manage potentially harmful patient behaviors. Physical and chemical restraints are the two common types of coercion used in psychiatry. Physical restraints refer to force, any mechanical device, material, or equipment that limit a patient's ability to move voluntarily. Chemical restraint done by administration of sedatives, hypnotics, antipsychotics, or dissociative medications. Restraints are commonly employed in emergency departments, psychiatry inpatient facilities, crisis centers. In hospital settings, restraints are used in physically assaultive patients who might be a harm to self or others, or who repeatedly attempt to abscond. Patients suffering from mood disorders, substance use disorders, schizophrenia, and other psychotic disorders are the ones who are commonly restrained. Need for study. There have been few studies on coercion in India since the introduction of the new legislation. Available studies are done in exclusive psychiatry centers and not in psychiatry wards in general hospital units. Few exist determining the frequency, clinical, and demographic factors of restraint of agitated patients during psychiatry inpatient treatment. And in this study, we want to determine how frequently patients will be restrained and clinical and demographic variables associated with restraints in our general tertiary care hospital setting. Our objectives are to assess the frequency of restraints and to assess the clinical and demographic factors associated with restraints. All agitated patients, irrespective of diagnosis, were admitted in inpatient care were included. Attenders who refused to give informed consent for the studies were excluded. Materials and methods. It's a cross-sectional study conducted over a period of 1 year. 99 samples were documented. Purposive sampling was done and approval from the Institutional Ethics Committee was obtained. Valid informed consent was taken from the patient's legally appropriate guardians. Socio-demographic details and clinical variables were collected using a pre-designed proforma. Scales used were CGI, Severity Subscale, applied at the time of admission, and ABS, Agitated Behavior Scale, and Staff Observation Aggression Scale revised, applied at the time of restraint. Results. Frequency we found was 9.46% in 1 year. we found that mostly a majority of patients who were restrained were aged between 18 to 30 years, were males, were not formally educated, were farmers, Hindus belonging to lower socioeconomic status, belonging to a rural community, and the type of admission they had was involuntary. Most of the patients had psychiatric past history of violence, and refusal to take oral medication. In majority of the restraint incidents, verbal de-escalation was attempted. Only 46.2% patients were receiving ECT, and the CGI score, the severity subscale score, was median was taken as 6. As we can see in this figure, schizophrenia has the highest prevalence among the patients, accounting for nearly 35% of the cases, and second being bipolar type 2 disorder, current episode manic, representing about 15% of the population, and other conditions such as schizophrenia with catatonia, psychosis, NOS, and volatile inherent induced psychotic disorder have lower prevalence rates, accounting for less than 5%. This is so 32.9% patients were restrained on the first day of admission, and 24.2 were restrained on the second day, 23.65 were restrained on day 3, and 10.54 were restrained on day 4. Frequency of different type of restraint was calculated. 76.8 patients were restrained physically and chemically, and 23.2 were restrained chemically. This is the table that shows the frequency of SOASR scores among the restraints. These are the subscales. It shows that there was majorly 42.4% times there were no understandable provocation. 53.5% the patient was only using verbal aggression. 50% the target of aggression was patient himself or herself or the staff member. Consequence, 58.7% time there was no consequence for any victim, and 75.8% patient was physically restrained and given parenteral medication, secluded or held by force, and 99 times, which means 100%, the staff was involved, and 54 times out of the 99 times, security was also called. The median ABS score was 41 with an interquartile range of 39 to 45, and the scores ranged from a minimum of 22 to a maximum of 49. Restraint events were classified to be of severe agitation were 87.9%. Discussion. So the study found out that 9.46% restraint frequency over 1 year, slightly higher than 8.7 reported in Switzerland and Austria, but lower than 66.5% from the study that we saw from NIMHANS. The NIMHANS study reported a 66.5 prevalence of restraint, with chemical restraints being most common, while our study showed 76.8 use of both physical and chemical restraint. This contrasts with the Swiss and Austrian study, where mechanical restraints were most frequently used, 55%, and the reason of restraint was 42.4% patient was restrained due to aggressive behavior without any clear provocation in our study, contrasting with the Swiss and Austrian study, where fall prevention and delirium were primary reasons. Then we found out that 99 times patients were restrained by nursing staff, and out of 99 times, 54 times security was called. Similarly, in a study conducted in Bangalore, restraints were performed by nursing staff. The Bangalore study also found out most restrained patients were males aged between 30 to 39, 49% being Hindus, just like our study. Just like our study, the NIMHANS study found that male gender, rural background, and low socioeconomic status were linked to a higher likelihood of restraint. A trial in Rio de Janeiro found that 24% of agitated individuals were restrained within 2 hours of admission, while our study showed 32.4 were restrained on the first day of admission. Then we saw that the study found conclusion. The study found a 9.46 restraint frequency, with most patients restrained both physically and chemically. Majority of restrained patients were males from rural, low socioeconomic backgrounds with a history of psychiatric illness and violence. Future research should explore long-term outcomes and develop strategies to reduce reliance on restraints in psychiatric care. Limitations: we found that the study shows a higher prevalence of restraint use but lacks discussion on alternative non-coercive interventions like de-escalation techniques. The small sample size and specific clinical setting limit the generalizability of the findings to other settings, with differences in clinical practices and local regulation affecting applicability. Longitudinal studies or RCTs would be necessary to determine whether the identified social, demographic, and clinical factors are direct causes of increased restraint use. These are my references. Thank you.
So you have a good one. You have commented on the median, correct? Median in the sample. You didn't do any mean of the sample?
No, sir.
Statistically, generally, when we do sampling, we do median, correct? Along with that, we need to do mean also, so that the sample, what we call the appropriateness of the sample could be ascertained. So whenever we do a study, we have to do both mean and mean.
Okay.
Any organic causes were there in the samples that you included? You said all educated patients were never visited, you said. So
Yes,
later
ma'am.
turned to be organic by cause.
Ma'am, there was a cognitive decline due to head injury. There was a patient. Then seizures patient was there with blindness was there, and schizophrenia continuous with seizure disorder was also there, and
Okay.
yes.
So these samples you observed it through the registry retrospectively, or
No. At the time of whenever the patient was admitted, the severities, CGI severity subscale was applied, and whenever the patient was getting restrained, both the other scales, ABS and SOASR were.
You also said that on the second day and the third day also there was a requirement of physical restraint. What might be the likely cause?
Mostly the cause was without any provocation. There was verbal aggression. Other causes were aggression towards staff for giving medications, aggression towards the attenders, patients' attenders for telling any basic instructions to them. They were
Not the disease process?
no. They were no.
And one more thing, usually delirious patients require restraint more. In my sample, I'm not seeing much. Only the third one is alcohol-induced delirium. Surprisingly, the percentage is very low.
It is taking over its predicted.
That is surprising, I think.
Yes.
Thank you, Dr. Shruti. Our next presenter is Dr. Triveni.
Good morning, everyone. I'm Dr. Triveni. I'm a second year junior resident. I'm Department of Psychiatry, NIMHANS Award. Today I'll be presenting a paper titled The Buffering Effect of Emotional Intelligence on Stress, Anxiety among the Nursing Students. Coming to the introduction, emotional intelligence is the ability to monitor, discriminate, and manage emotions in oneself and the others. EI plays a pivotal role in managing stress and anxiety, especially in nursing students who face unique stresses due to their demanding academic and clinical environment. The relation between EI, perceived stress, and anxiety is well documented, with high EI being linked to better stress management and coping strategies. Nursing students often experience elevated anxiety levels, impacting their academic performance and well-being, particularly during challenging times like COVID-19 pandemic. Studies have shown a significant negative correlation between EI and perceived stress, suggesting the students with higher EI handle stress more effectively. A positive correlation between EI and anxiety symptoms has also been observed, indicating the higher EI may lead to increased emotional awareness and sensitivity towards the anxiety. This particular study tries to fill the gap by focusing on the Indian context, exploring how EI influences stress, anxiety, and coping strategies among nursing students in India. Coming to the aims and the objective, the primary aim of the study is to investigate relationship between EI, perceived stress, and anxiety among the nursing students. Coming to the objectives, to assess the level of emotional intelligence, perceived stress, and anxiety among the nursing students, to examine the correlation between EI and socio-demographic details, to examine the correlation between EI and the perceived stress, and to explore the relation between EI and the anxiety symptoms in the nursing students. Coming to the methodology, it's a 3-month cross-sectional observational study. Participants in the studies included nursing students from undergraduate program and were selected through convenience sampling. A total of 150 students were recruited according to the convenience sampling. The inclusion criteria required students to be currently enrolled in this program and to provide informed consent. And the students excluded are those who did not give the consent and students diagnosed with major psychiatric disorder or drug dependence as per the ICD-11 diagnostic criteria. Coming to the assessment tools utilized, a self-designed semi-structured performer used for socio-demographic details, the Shuttle Self-Report Emotional Intelligence Test, a Pursuit Stress Scale, a Hamilton Anxiety Rating Scale, and ICD-11 diagnostic criteria. Coming to the results, you can see that most of the students were 21-year-old, and it was a female-dominated patient profile. Most of them belong to the nuclear families, and most of them hailing from urban residency, and which had a good academic excellence. Coming to the correlation between EI, perceived stress and anxiety, you can see that emotional intelligence has a negative correlation between the perceived stress, and emotional intelligence has a positive correlation between a HAM-A score. Coming to the discussion on socio-demographic characteristics, this nursing students cohort predominantly consists of females, reflecting the gender imbalance typical in the profession. The majority of them comes from the nuclear families, reflecting the changing family structure in the urban areas. The high academic achievement, with 57.9% attaining distinction, indicated the capability but also highlights potential stressors. The career satisfaction at 71% indicate a positive professional outlook contributing to emotional well-being. Coming to the discussion of emotional intelligence, perceived stress and anxiety. The study revealed a significant negative correlation between the EI and perceived stress. This suggests that higher EI is associated with low perceived stress among the nursing students. The finding align with the existing literature indicating individuals with higher EI are more adept at managing stress, as EI enhances the emotional regulations and scoping strategies essential for handling nursing educational demands. We also saw a significant positive correlation between EI and anxiety symptoms. This suggests that students with higher EI may have greater awareness of their anxiety symptoms. Increased emotional awareness, a key component of high EI, may lead to better recognition and reporting of anxiety symptoms, indicating heightened sensitivity rather than the increased anxiety. Interestingly, the correlation between the perceived stress and anxiety symptoms was not significant. This finding suggests that individual differences in the stress perception and anxiety manifestation. Coming to the influence on the demographic and the lifestyle factors, age significantly correlated with the perceived stress, indicating that older respondents experience more stress because of the increasing burden, whereas they report lower anxiety and emotional intelligence. This may reflect increased responsibility that comes with the age, whereas balanced by better emotional regulation, which comes with the life experience. Working hours correlated positively with anxiety and negatively with EI. This suggests excessive work can heighten anxiety, hinders the emotional regulation, emphasizing the need for balanced work schedules. Coming to academic performance, correlate positively with anxiety and EI. High-performing students may experience more anxiety but also demonstrate higher EI, which can aid in managing academic stress. Career satisfaction is positively correlated with anxiety. This contradictory finding suggests that satisfied students are more aware of the future professional challenges, leading to increased anxiety. The future researchers should focus on longitudinal studies to assess the long-term effects of EI, training on the nursing practices and patient outcome. Coming to the conclusion, emotional intelligence play a crucial role in managing stress and anxiety among nursing students. Higher EI is associated with low perceived stress and increased awareness of the anxiety symptoms. Demographic factors like age, family structure, and work hours significantly influence the stress, anxiety, and EI. Coming to the strength and limitation of my studies, strength being it's a comprehensive focus. It has a comprehensive focus. The validated tools were used in this study. It was a real world relevance was there, and focus was on understudied population. That is, most of the previous studies were done on the other professional, but in an Indian context, that too in the nursing students were not done. And coming to the limitation of my study, it is a cross-sectional study, and it had self-reported data, which would lead to bias, and it was a convenient sampling and lack of control for the confounding variables. And these were my references. Thank you.
But they were students only. They were not posted for any night duties or anything.
Yes, ma'am, they were. Actually, this was a undergraduate college, nursing college. It was from first year to 4 years of BSc nursing. Only the 4th years were posted for the night duties or emergency duties. So I had mentioned it, the number of hours worked.
Do you think there is any correlation between those night duties and perceived stress levels?
Yes, ma'am, it is. There is a significant correlation between the working hours and the anxiety and perceived stress. As they come in direct contact with the patients, their perceived stress would be more, and the anxiety levels will also correlate with the same.
And most of them happen to be from the state of Kerala. So was there a language barrier? Did it come anywhere in terms of stress to the individual? This is one common factor that we come across actually.
Yes, ma'am.
In clinical setting.
This was a college located in Dharwad. So most of them were Kannada speaking students, and they were belonging from Karnataka itself. So they didn't report of much of the language barrier. Thank you.
Thank you, Dr. Triveni. Our next presenter is Dr. Savita. Please start.
Good morning. My study is on the assessment of suicide risk in patients with anxiety disorders at a tertiary care hospital, a cross-sectional study. So anxiety disorders are a spectrum of psychiatric conditions characterized by persistent fear, which is out of proportion to the situation, often leading to avoidance behaviors. The American Association of Suicidology enlisted anxiety disorder as an important risk factor for suicide. However, while various studies have shown a positive association between suicidal risk and anxiety disorder, the actual relationship is rather controversial, as many studies report that having these disorders do not raise the likelihood of suicide. So the need for this study is that the association between anxiety disorders and risk of suicide was inconsistent across studies. The aim of the study is to estimate the lifetime and current suicidality in patients with anxiety disorders. It's a cross-sectional observational study conducted at the Department of Psychiatry, Kasturba Medical College, Manipal, a tertiary care center in the south of India. The inclusion criteria, the age was 18 to 65 years, both genders, both inpatients and outpatients, and those diagnosed as having anxiety disorder as per the ICD-10 by a consultant psychiatrist. Exclusion, those with a comorbid psychotic illness and intellectual deficits, those in substance withdrawal except tobacco, patients with any serious physical or neurological impairments which may interfere with assessments, patients with pre-diagnosed organic causes of anxiety disorder, example hyperthyroidism. Ethical aspects, all participants were given a subject information sheet and written informed consent was taken from them. The IEC approved the study. Registration was done in the CTRI before the first participant was recruited, and the principal investigator underwent the certification course for the administration of the CSSRS, after which the data collection was started. It was a time-bound purposive sampling method based on prevalence rates in Indian studies, pre-COVID patient census and previous research. A sample size of 170 was estimated. However, the principal investigator could recruit only 66 patients because of the restrictions imposed by COVID at the time. The measures used were a semi-structured socio-demographic and clinical data proforma, the CSSRS for the recognition and assessment of suicidal risk, and the WHO-BREF for assessing quality of life. The collected data was analyzed using SPSS version 16. The results, the socio-demographic and the diagnostic categories of the patients. So this is showing the age, gender, family type, marital status, educational status, occupational status, socioeconomic status, and the diagnosis was PAN diagnosis. So basically we had panic disorder, GAD, mixed anxiety depression, social anxiety disorder, and anxiety disorder unspecified. The frequency of psychiatric comorbidities in the patients. So comorbidities present, we had tobacco dependent syndrome, borderline personality, major depression, ADHD, and anancastic PD. In 46 patients, there was no psychiatric comorbidity. The WHO-BREF scores in patients showing the mean raw scores and the standard deviation for the various domains as well as the total score in the patients. The frequency distribution of suicidality as graded on the CSSRS. This is the current suicidal ideation, the number in the percentage, and the lifetime suicidal ideation, the number in percentage on the various grades of severity as per the CSSRS. So in patients with anxiety disorders, 12.1% had current suicidality, while 40.9% had lifetime suicidality. So among them, 6% reported current active suicidal thoughts. The association between psychiatric comorbidity and suicidal ideation. So this is comorbidity present absent and the suicidal ideation present absent, the chi-square and the p-value. The relationship between quality of life and suicidality. So this is the table showing the same, the Hukal-Breff domains and the suicidal ideation current as well as lifetime. While more patients with comorbidities had suicidal ideations, the relationship between the presence of comorbidities and suicidal ideation was not statistically significant, and we found no association between suicidality and quality of life. So our study found that more than 1/3 anxiety disorder patients have lifetime suicidality and 1 in 10 can have current suicidality. Previous studies have found that among individuals reporting a lifetime history of suicide attempt, over 70% had an anxiety disorder, and this presence of anxiety disorder was significant even after adjusting for comorbid conditions as well as sociodemographic factors. A study based on nationwide medical records review found that anxiety symptoms, 50% of individuals had reported had anxiety symptoms in 50% of individuals 1 week before the suicide. And again, even after adjustment for mood disorders, this was found to be significant. We found no significant associations of suicidality with comorbid psychiatric conditions or quality of life in our sample. However, this is contrasting to what previous studies have found as far as the association between quality of life and suicidal risk. And our findings with regard to, that's the same thing I said. So previous studies have found that people who die of suicide have lower quality of life, and anxiety disorders like social phobias and GADs were found to be more frequent and statistically significant for patients at risk of suicidal attempts. So our limitations were that we have had a very small sample size, and also that our sample was restricted to a tertiary care center. The severity of the symptoms of anxiety disorder was not assessed, and no scale was used for assessment of comorbid diagnosis. Conclusions: people suffering from anxiety disorders can have both current as well as lifetime suicidal ideations and self-harm behaviors. This may be independent of having other comorbid psychiatric conditions, and hence screening for suicidal ideation is imperative while assessing patients with anxiety disorders. Thank you.
Good one.
Thank you, sir.
You didn't use any rating scale.
To assess the severity, we did not, sir. Did not. It was a clinical diagnosis based. Only for quality of life and suicide assessment, we have used scales.
The comorbidities also you have excluded. That would be in a confounding way.
Yes, sir.
So in the follow-up to this, try to see that the comorbid
yes.
conditions also excluded.
Yes. Thank you. Yes, sir.
You have not used any scales for comorbidity.
Yes, sir.
But clinically, in the course of your assessment, did you find any comorbidities? Though you have not used any formal scales?
Yeah, we had comorbidities, sir. These are the ones that we found.
Only 1.5%?
Borderline and major depressive, only one, because our sample size itself was quite small. 66 total, yeah. The COVID restrictions were during that time, so. This was in KMC Manipal. Yes. No, madam. We didn't specifically look for that, no. Yeah, thank you. Thank you very much.
Thank you for all the participants, and I take the opportunity to thank our judges. We are running out of time, so without further delay, we'll start the next session. Over to Dr. Swati.